Thank you. Okay, so before we get started on today's lesson, let's just do a quick recap of some of the things that we went over the last time. So we did have a drawing of a spinal cord, right? Whenever you look at the spinal cord, remember you had a butterfly in the center, and that butterfly in the center was that white or gray?
Gray.
Gray, perfect. So everything around that butterfly is all of our white. We reference those as columns, or what was that AKA for column?
Funiculus.
Funiculus, good. So whenever we're looking at our spinal cord, we also see these things that come off of the cord. Remember, we call those roots. So we remember that one of the ways to distinguish between anterior versus posterior was to look at our dorsal root and look for that bubble that's called the dorsal root ganglion, right? You guys remember that? Now, what information runs in the dorsal root?
Sensory.
Sensory, perfect, okay? You have to know that sensory is going to be in that dorsal root, which means where is our motor or efferent information going to be running?
The anterior root.
The anterior root, perfect. So whenever we combine the dorsal root and the ventral root, what do we get?
Next nerve.
Spinal nerve, okay? So spinal nerve comes together as the dorsal root and the ventral root. After that spinal nerve comes together, then it's going to bifurcate off into a dorsal rami and a ventral rami. Where did we say the dorsal rami was going to go? You guys are like, not sure. Skin and muscles of the back. Okay, dorsal rami, skin and muscles of the back. Ventral rami was going to go on to create these things we call plexuses. And that's what we're going to be learning about today, is we are going to see how the ventral rami are actually going to create these plexuses, and the plexuses are then going to give rise to what we call peripheral nerves. So the reason why you can feel things in the very tips of your fingers is because of the peripheral nerves that come from the plexuses, or all the way in the tips of your toes because of the peripheral nerves that are coming from the plexuses. So we're going to walk through these things today, and you're going to see that this is going to be a lot of different terminology that you're going to have to remember, because we are talking about how do we innervate all different portions of the body. So it's going to feel like it's a lot of information, because it is, and I'm going to try to help you guys understand where to really focus your time and your attention, so that way you don't feel just completely overwhelmed by just this portion of the PowerPoint alone. So before we get into our plexuses, we first want to establish information about the creation of this nerve, because we saw that it was an anterior root and a posterior root that comes together to help create our spinal nerve. But there are going to be connective tissues as well as blood vessels that are going to be within this nerve. As you can see here, we have the Epineurium. Epi, whenever you see that particular word, root, you want to think, or I should say prefix, you want to think about surrounding something. So this is the outermost connective tissue layer that's going to surround the entire nerve itself, okay? The perineurium, peri is the middle layer. This is going to separate the nerve into what we call fascicles, which are axon bundles. I'm going to show you a picture of this here in just a second. And then our third is our endoneurium. If you see the prefix endo, always think indoors. This is always going to be inside. So the endo is the innermost layer that will surround each individual axon. If we look at this picture here, what you can see here is this entire nerve is going to be created by multiple neurons. So we already drew the neuron, right? We drew a multipolar neuron. We saw the axon, we saw the dendrites, we saw the soma. So what you want to focus your eye on right now is this axon right here, and you can see that it's surrounded by this myelin. So this myelinated axon is going to be surrounded by a piece of connective tissue called the endoneurium, the innermost connective tissue layer. Then we have multiple myelinated axons that get wrapped in endoneurium, and they're going to be surrounded by another layer of connective tissue called perineurium. And this is what creates our fascicles. So think about it like this. Let's say you have a blue crayon, and on that blue crayon, you have a piece of wax paper that wraps around it, and it basically tells you what kind of blue it is, right? Royal blue. Let's say that this one says royal blue. Let's say that this one says baby blue, and this one says cerulean blue, and this one says lapis lazuli blue. You get my point, right? We have multiple crayons that are going to be wrapped up by a piece of wax paper, that's the myelin, and each one of those we're then going to wrap in a connective tissue called endoneurium. Once we put all those crayons together in a big bundle, then we can surround it by another piece of connective tissue. So now if we have 100 different blue crayons wrapped together with a connective tissue layer, we would call that a fascicle, okay? So multiple neurons wrapped up, surrounded by perineurium, makes a fascicle, and then we put multiple fascicles together, throw some blood vessels in there, and then we surround it with that last outermost layer called the Epineurium, and that gives us our entire nerve. So what you see is there's going to be multiple neurons that are within each individual nerve. Multiple. Very important to understand the difference between the neuron and the nerve. Because yes, the neuron is the CEO and it's going to be able to send signals, but we have hundreds of CEOs inside of just one single nerve. So lots of information can be running through this nerve, okay? Those spinal nerves, remember, they are going to come out laterally from each spinal cord segment. We've already shown that they are formed by anterior and posterior roots. And I already told you guys all spinal nerves are mixed nerves. So this is just kind of a recap. Remember, the spinal cord has bilateral symmetry. So you'll have a spinal nerve that's going to come out on the right, as well as one that's going to come out on the left at every individual level of the spinal cord or the spinal column. So our peripheral nerves are going to be created by branching and resorting our spinal nerves. And all of these peripheral nerves are also going to be mixed nerves, meaning they will carry both the sensory and the motor information, and they have the same connective tissue layers as the spinal nerves that I just showed you guys. So they are continuous with each other. When we get into peripheral nerves, because there is so much branching and resorting, it can kind of become a little bit confusing. So that's why I'm kind of starting off with this recap so that you understand where is all of this coming from, how did we get here, how did we create all of this. When we look at the peripheral distribution of these spinal nerves, remember we're having sensory and motor innervation. We've already drawn the posterior and the anterior rami on your picture. And I told you guys we're going to talk about the white rami later on. Whenever we get into the autonomic nervous system, then you're going to hear me start talking about the white rami and the gray rami. So that's coming later on. But what I want you to see on this slide right here is this new term, dermatome. The dermatome is a very important structure. So derm coming from the word dermis, meaning skin. Tome meaning a section or an area. So this is a skin section that is going to be supplied by a single pair of spinal nerves. Okay, that means that we're going to be able to have sensory information that will be picked up on every different portion of our skin that we can trace back to a specific spinal nerve. I'll talk about peripheral neuropathies here in just a second, but first, before I get there, I want to show you this particular map. On this portion, you can see the anterior. This portion, you can see the posterior. So we have the dermatomes on both the front and the back of the body. And what you see here are all of the different areas where we can have skin supplied from a spinal nerve. So let's look at one particular area, like let's say right here across the nipple. This is going to be the area supplied by T4. Whenever we look at, let's say, the arm, You can see here as we come down, it gets a little more funky in the arms and the legs than you can see across the chest. On the chest, it's kind of like stacked, C5, T1, 2, 3, 4, 5, et cetera, et cetera. But when we get into the limbs, it gets a little bit weird. There are multiple different dermatome maps that are out there. So if you go Google dermatome map, you might find 30 different varieties of this. PTs get some, OTs get some, nurses get some, and everybody's is always a little bit different. But this is the one that's in your book, so that's why we're going to use this one, okay? Whenever you're looking at this, what this means is if we have a patient who cannot feel anything on the lateral aspect of their forearm in the antebrachial region, then that means we could have a problem with the C6 spinal nerve. Maybe. We always have to be a detective and investigate a little bit further. So this could lead back up to damage at the spinal nerve level, or this could be something that's actually occurring that's causing damage just in that forearm level. So we have to kind of evaluate and look for other clinical indicators as well. If we say that somebody comes in to the clinic and they're saying, okay, I have a lot of pain that's going down the back of my leg, so posterior portion, okay, it's going down the back of your leg, where is your pain? Is it like the lateral aspect of your hip? Is it literally like down the entire back of your leg? Does it come over here to the medial aspect of the lower leg? Like, where is it? We can start to narrow down some of the diagnoses that we want to maybe give or think about for that particular patient's condition. So again, that's why detective work is very important, but you won't know how to narrow if you don't know where these dermatome levels are and what spinal nerve is supplying which section of skin. So sometimes whenever I go out of town, because I told you guys I have to travel a lot, whenever I go out of town, I will take a pinwheel and I will take a Q-tip. And so what I can do is if somebody is telling me that there's something wrong with their right leg, then I'll evaluate all of the dermatomes on the right side and on the left side to see if they can feel the difference between sharp and soft. So if they're having trouble differentiating between a pinwheel, which is very prickly, and a Q-tip, which is very soft, then I know that we have a problem, and I'm going to use which dermatome am I on to trace it back up to which level of the spinal cord is that coming from. And does it then connect with what I see on their MRI? Because if their MRI says they have a herniated disc at, let's say, L1, but what they're telling me, all of their signs and symptoms are pointing to L5 and S1, then they may think that the herniated disc is causing their problems, but I know that that's not the area of the dermatome that is supplied by where their herniated disc is. I'll show you a picture of a herniated disc in a minute. So it helps us with basically clinically correlating what we're seeing from multiple different areas. Okay, so this is sensation. We can easily check this with a pinwheel and a Q-tip, but we always want to do it bilaterally. So that way we can evaluate both sides of that particular patient, and we always want to do it with further clinical information. One of the ladies that I used to live next to, so I used to live in Allen, and my neighbor, whom we basically just decided she was going to be our adopted grandmother, my neighbor, her husband, which is now her late husband because he's no longer here, was a type 2 diabetic and also had Alzheimer's. One day I came over to the house and I had just made this soup, and she did not answer the door because she was in the backyard doing the gardening. And whenever he answered the door, I said, I will take this to the table so you don't have to carry it, because I knew it was hot. And he said, no, I'm going to carry it. I will carry it. Well, as a type 2 diabetic, you can start to lose feeling in the periphery, in your fingers and in your toes, because of the damage that has been done to the nerves because of that constant high blood sugar. So blood sugar is incredibly harmful to nerves and then to the microvasculature that you find in your fingertips and in the tips of your toes. But he would not allow me to give it to him. So he was being very hard-headed. And I kept saying, I'll take it in, where's Miss Patsy? I want to see her. And he was like, no, I'm going to take it, and she's busy in the backyard. So he ended up taking the soup. And I don't know what happened after that because he closed the door. And I went back to my house. And then a few days later, whenever I went over there to say, hey, did you like the soup? How was it? She loved the soup and everything was good. But you know what I noticed? Her husband now had on gloves. And from that day forward, I never saw him without those gloves. And she never told me, but I have a sneaking suspicion that he burned his hand on that soup. Because when you can no longer feel things, you don't know if they're hot. The pain perception is no longer there. And that information could not travel to his brain. And so I'm pretty sure he probably burned his hands. And from that day forward, she just decided in order to keep him safe and protect him, he will wear these gloves at all times. Even in the summertime, he had on gloves. So it's very important that we know what's going on with these dermatomes, so that way we can either assess it with the spinal cord injury, or in his case, this peripheral neuropathy. This was caused by type 2 diabetes. So there's various illnesses that can do this. It's not just trauma or compression to a spinal nerve level. It can be other things as well. So very important to let the type 2 diabetic patients know that if you don't get control of this and you don't handle your blood sugar and keep it regulated in by whatever means you need to do, diet, exercise, making sure that you're taking the right things, it will get progressively worse. And peripheral neuropathy is one of those things that can happen where they no longer have the sensations that they can pick up in the periphery of their body. So if we have, let's say, something that looks like this, this is a representation. So just to orient yourself here, this is the vertebra. This is the spinous process that you can feel on your back. So this is the most posterior portion. This is the anterior portion. When we're looking at the vertebra, the bodies should look something like this, nice and smooth. You can see how this one is no longer smooth. The cushions that are in between these vertebrae are called intervertebral disc. They are filled with a jelly-like substance. And if these vertebrae start to degenerate over time, which does happen as you age, things will change within your spinal column. But also if you are chronically dehydrated and you don't have enough fluid that will help cushion these vertebrae, then these can start to collapse. And then the jelly fluid can leak out to the exterior. This is what we would call a herniated disc, okay? If the fluid comes out and it puts pressure on a nerve, you can see here, this is representing a pinched nerve. And at that point, we then may also get some issues with pain or sensations of tingling, numbness, irritation that can go in a particular spinal nerve direction. And we can use the dermatomes to figure out, again, like I said, where exactly is that coming from. So whenever we're looking at our plexuses, these are networks of nerve fibers. You can see here that we have the spinal nerve coming from the spinal cord. Remember, our plexuses are going to come from the ventral ramus of the spinal nerve. So anterior rami, and this allows multiple spinal nerves to supply the same structures. So what you're going to see as we walk through some of these nerves is that it's not just going to be just C5, okay? It's not going to be just L1. It could be L1 through L4. So different nerves will pick up different spinal roots and combine them all together into one in order to create this peripheral nerve. Whenever we have issues with nerve problems, in addition to the terminology peripheral neuropathy, we also have these other words, radiculopathy and radiculitis. So you'll have to write down these definitions. Radiculopathy is basically like what you see right here in this picture. That is the compression of a spinal nerve root. A compression of the spinal nerve root that then causes pain or interference to normal function because that spinal nerve cannot efficiently communicate with its associated structures. So radiculopathy is due to compression of a spinal nerve that can then lead to things like pain or interference with proper function because that spinal nerve can no longer communicate with its associated structures. Okay, radiculitis, if we see the word, the suffix itis, remember, always think inflammation. So radiculitis is a different term. Sometimes you may also hear, instead of radiculitis, radicular pain. That term means that we have pain traveling down a spinal nerve due to either inflammation or infection in the area. Okay, radiculitis or radicular pain means that we have some sort of pain traveling down the nerve due to infection or inflammation. So we got all these different terms and all of these different things that can go wrong. So as we walk through our 4 different plexuses, the cervical, the brachial, the lumbar, and the sacral, whenever you start to see these nerves, what you want to pay attention to is where do they go? Because ultimately where they go is what's going to be affected if they cannot work appropriately, okay? All right, so here's the big picture. You definitely want to make sure that you star this particular slide, because this one will break down for you. The cervical plexus is going to basically be from nerve roots C1 through C5, okay? So starting in the very top of the neck, at the very top of the spine, from the very first cervical nerve to the 5th cervical nerve, you get your first plexus, which is called the cervical plexus. Over here on the right-hand side, what you can see, let me move this. What you can see are the major nerves that come from the cervical plexus. So whenever we're looking at this, you can see lesser occipital, greater auricular, et cetera, et cetera. This one, I want you to put a star by, the phrenic nerve. And the reason I want you to put a star by this one is because this nerve ultimately is going to go down to innervate the diaphragm. So we see the diaphragm in the lab, like on the torso man model, you can see the diaphragm underneath the ribs. Remember, the diaphragm is what divides the thoracic cavity from the abdominal pelvic cavity. So a lot of people forget that the diaphragm being in the middle of the abdomen area actually comes, the nerve actually comes from the very top of the cervical spine. So they expect that everything in the cervical area from the cervical plexus is just going to stay up near the head. And they forget that that phrenic nerve actually runs down to the diaphragm. So the diaphragm helps us with what? Breathing. So if something were to happen to you, let's say like if you were in a motor vehicle accident and you get whiplash and you are impacting negatively the phrenic nerve because of the spinal nerve origination where the phrenic nerve actually comes from, during that whiplash incident, you may experience shortness of breath. Okay, so if you're working in the ER or something like that, if somebody comes in with an MVA, there's a lot of things that you have to pay attention to and you have to monitor and check to make sure that that person is okay. It is possible to herniate in the cervical spine, just like you can herniate anywhere else in the spine. So doing so will definitely interfere with that phrenic nerve if it's herniated in just the right spot. Okay, so that's important to remember. Brachial plexus, C5 through T1. What does brachial mean?
Arm.
Arm, perfect. So this is the one that is going to go supply the upper limb or the arms. Okay, so from C5 through T1, pectoral girdle, what's pectoral?
Your pecs.
Chest, perfect. So we're going to be chest and arm for our brachial plexus. You can see over here the major nerves of the brachial plexus. The axillary, what does axillary mean? armpit, right? So going down towards the armpit, axillary, musculocutaneous, radial, which we should always associate with the thumb, whether it's the nerve or the bone or the artery, the ulnar, and the median. Now, here's the thing about learning these new names of these nerves. If you learn the names now, it makes your life so much easier when you get into 2402 and you have to identify all of the arteries in the body, because these nerves also have associated blood vessels. Okay, so you can see the axillary nerve associated with the axillary artery, radial nerve associated with radial artery. So their names are repetitive. That means that there's less information for you to remember later on if you can go ahead and put it in your brain right now. Okay, and then see this, the thoracic nerves. So write a little note to yourself, there is no such thing as a plexus between T2 and T11. You see there's a huge jump from T1 to T12 when we're talking about our plexuses. We don't have a plexus in the thoracic area. And the reason for that is because the thoracic nerves are going to go on to innervate muscles that are in the chest, the abdomen, and even a little bit in the upper back area. So they'll go on to innervate those muscles, as well as what we call in between the ribs, intercostal areas. So costal meaning rib, inter meaning in between. So those thoracic nerves are going to go to those areas within our thorax. Okay.
You said there was no such thing as plexus between what again? I'm sorry.
So nothing between T2 and T11. Okay. All right. We've got the lumbosacral plexus. You can see that this is a combination word. Some books will reference it as lumbosacral, and some books will divide it out as lumbar plexus, sacral plexus. We're going to divide it out so that way it's a little bit more clear. The lumbar plexus will be from T12 to L4, and the sacral plexus from L4 to S4. Here again, you can see all of the major nerves from each of those plexuses. The sciatic nerve, this big, huge, chunky one right here, is the largest nerve inside of your body. Okay, this is why there are multiple people who will experience things like sciatica, because the nerve is so big that if anything is moved out of position, remember last time I taught you guys the word subluxation. So if any of your vertebrae are subluxated, they're not in their normal anatomical alignment. If any structures within the pelvis are subluxated, or sometimes even if you have inflammation in the muscles within the gluteal region, it can cause that nerve to pinch, and it will cause that pain that shoots down the back of the leg. So a lot of times moms will experience this whenever they're pregnant, because that's just one of the things that we kind of go through in order to bring a baby into the world. We go through a lot more than that, but that's the story for another day. But that pressure, because our anatomical alignment has changed as we are growing this baby inside of our uterus, so it's causing things to shift, which can then sometimes put pressure on that sciatic nerve because of those shifts. Okay, so those are your plexuses. Make sure that you know the name, the associated spinal nerves, and then you want to know the major nerves that are coming from those plexuses. So that's over here on the right-hand side. I have some word slides for you guys. For those of you who do like words, a lot of this is the things that I have already said in relation to the picture. So again, you had your star on the phrenic nerve. You can see here phrenic nerve is C3 through C5. Whenever I was in school, what we used to say was C3, C4, C5 keeps the diaphragm alive. So that way we would always remember if we did have an MBA incident or there was some sort of herniation in C3, C4, C5, and we had a shortness of breath patient, and we need to pay attention to those things. Okay, C3, C4, C5 keeps the diaphragm alive. Here's another picture so you can look at the lateral view. As we move forward in the semester, we are going to go into the muscular system. And so this picture just basically shows you some of the muscles that these nerves are going to go to. So now what we've done is we've taken the nerve, you hear that you see the spinal segments right here. This will tell you where that nerve is going. So remember, those are the important things, because where the nerve is ultimately going to supply means that if there is not supply to that area, we are going to have dysfunction in that particular area. We have some models in the lab that will show you this representation of these nerves that come from the cervical plexus, as well as these muscles here that are going to be supplied from one of the nerves from the cervical plexus, antecervicalis, goes on to supply many of these muscles that you can see on the models and that you will have to learn for the third practical, okay? And then brachial plexus. Now this one is quite complicated, okay? There's a lot of detail and specificity to the brachial plexus. So definitely you want to remember that this is C5 through T1. Okay, we said pectoral girdle, a little bit of upper back, and then upper limb. The rami first form what we call trunks. So we're going to have this successive breakdown of different terms in order for us to create this terminology. So let me show you a picture as I talk through this. You can see here C5 through T1. So here's our spinal nerves that we will start with. So the anterior rami roots, C5 through T1. Let's see if I can move that down. The trunks are going to be how these roots all converge, and we're going to form a superior, a middle, and an inferior trunk. Now look at what's happening. We've got C5 and C6 coming together to give us a trunk. We've got C7, who has its own trunk, and then C8 and T1 coming together to give us an inferior trunk. The trunks are ultimately going to give us divisions, and even though this picture is not labeled, it's either an anterior division or a posterior division, so don't worry about that, but the anterior divisions and the posterior divisions are going to start to combo things up. So what you can see here is we just comboed what was C5 and C6 originally. We're now taking a piece of C7 with that in order for us to get down here and start creating some peripheral nerves. So there's this sorting and redistributing of the spinal nerve ventral rami throughout the brachial plexus, which makes it very, very specific in how we're ultimately going to get innervation to different parts of the body. So let's look here. Dorsal scapular, you can see it coming off of C5 right here. So dorsal scapular nerve is going to go to the back. Your rhomboid muscles are in the back. The levator scapula is going to be kind of the back and the upper neck. So basically the levator scapula is going to help you with elevating your scapula. You'll learn this muscle, like I said, as we go towards practical 3. So if something happens to just C5 alone, and we have just a rhomboid levator scap issue, then that means the rest of the brachial plexus could be spared and everything else may be okay. So that's why it's important to become that good detective to figure out, okay, well, I know that this goes here and that goes there. What is coming together with it versus what is spared from it will help you with narrowing down that diagnosis for that particular patient. You can see here we've got other muscles like subclavius, supraspinatus, and infraspinatus, also going to be in the upper back, pec muscles in the chest, subscapularis and teres major, also in the upper back, latissimus dorsi is the back, the deltoid, we know that's the shoulder, teres minor is going to be in the back, and then we have this medial antebrachial cutaneous. Whenever you see something that says cutaneous, you need to think skin, okay? So cutaneous means that this particular nerve right here is going to provide the sensory from the skin over the anterior and medial surface of the arm and forearm. Now these other nerves here, musculocutaneous, medial, ulnar, radial, these are the nerves that we saw as being our primary or major nerves from the brachial plexus in the previous slide. So we're going to go to a separate page for them, okay? I think we are. It won't let me move the screen. Let's see. There we go. Okay. So 1, 2, 3, 4, 5. These are the 5 that are the major nerves from the brachial plexus. These 5 you definitely want to make sure that you do remember, because you will see this very easily in multiple different lab models. You could get the arm model from the muscular system and see the little yellow fiber structures that are running through the arm. And you can then identify these different nerves that are coming from the brachial plexus. So let's talk about them in a little bit more detail. Musculocutaneous. Oh, and what you'll see is, take note of this. So make a star or circle this. Look at that. C5 to T1. They are all C5 to T1, C5 to T1. This one is C6 to T1, C8 to T1. They're all very, what's the word I'm looking for? Thick and rich with multiple spinal nerve roots, okay? So especially musculocutaneous and radial, because you can see that they take up all of the ventral rami from the entire brachial plexus. Now, as you look at your arm, remember always anatomical position. So anatomical position is incredibly important in helping you to identify appropriately. We do have a lab model that is not in anatomical position, so you do have to watch for it. Its hand is actually turned backwards. And whenever you pronate your palm, that means that you move from anatomical position and put your palm down. That's pronation. When you pronate, what you actually do is you cause the radius and the ulna to overlap each other in a crisscross fashion. And that means then that your radial nerve is going to move towards the medial aspect of the body on any model that is not in anatomical position. So if you don't watch that, you'll miss that. Okay, so make sure you always are looking for anatomical position, and anytime you want to say something about radial, make sure that thumb is in the area where you are, okay, on your models, on your pictures, whatever it is. So we always associate radial bone, radial nerve, radial artery as being with the thumb, okay, and the ulnar is with the pinky. So if we have a problem with radial nerve, so look here, here's your radial nerve, comes down and heads towards the thumb. If we have a problem with radial nerve, then it's going to show up along the lateral aspect of the arm and into the thumb. If we have a problem with ulnar, it's going to show up on the side, on the medial side of the arm and into the pinky, because you can see how it runs along the medial aspect and in towards the pinky finger. Okay, so there's lots of muscles that are listed here. Musculocutaneous, you can see biceps, the brachialis, the coracobrachialis. Some of these muscles you may be familiar with, some of them you may not. Whenever you're starting to learn muscles, what I will tell you as a helpful hint to you is these words are not willy-nilly. So a lot of people think that these are just really crazy, weird words because they have no idea what these words actually mean or what they sound like, or how to say them. They all mean something. There is a rhyme and a reason to everything. So I encourage you to get a lab manual that will translate those words for you. If your manual does not translate it for you, then I can send you a picture of something that will help you with translation. So all of the words, whether you see brevis or whether you see longus, flexor, extensor, carpi, all of those words have meaning. And it's very important for you to know the English meaning because it makes it easier for you to remember the actual names and get those things right. Okay, so flexors, adductors, versus abductors. Whenever you're looking at things like adductors mean that we add that to the body. So we bring it in closer to the middle of the body. So your adductors are usually going to be on the medial aspect of your arm or the medial aspect of your leg, because they are muscles that help you to bring things into the center, versus abductors, they're on the lateral aspect because they help you to take things away from the body. So abduction, like if you were to abduct a kid, you would take them away from their parents, right? Abduction means you take away. So it's very easy to get some things convoluted because that's just a one-letter difference. The adduction, ADD, versus abduction, ABD. It's a one-letter difference, and it's very easy to miss those things or mess up on those things. So those are things that you really kind of want to pay attention to. But again, you got to look at your body. Where are you, and what would logically make sense to be in that particular area based upon that function of that particular muscle. Okay? All right. Now, when we're looking at this picture, you can see here we still have radial ulnar median nerve, all the things that you're already familiar with, but now you're like, why do we have all these new colors? Because this is showing you that whenever we are looking at the sensations of the hand, if you wake up in the morning and you have tingling in your fingers, it could be for a number of different reasons. It could be because you slept wrong, or maybe your neck was, in an awkward position that then put pressure on those spinal nerve roots that come out to then later on innervate your hand. It could be because you compressed the blood flow, so it could be a circulation issue. So there's a number of different things that could be going on, but what you can do is you can look at your hand and you can figure out where the underlying problem may be at. So again, radial being closest to the thumb. Now we can see that the median nerve is going to innervate the first 3 digits, and then you have part of the 4th digit. Is this part of the 4th digit innervated by the median nerve? Is this the medial aspect, or is this the lateral aspect of the ring finger?
Medial.
Medial, perfect, okay? So you have the medial aspect of the ring finger innervated by the median nerve. The ulnar nerve will do the pinky and the lateral aspect of the ring finger. Flip it over, so pronate, palm down. Now you will see there's radial nerve innervation in a much greater sense on the dorsal aspect of the hand than there is on the ventral aspect of the hand, okay? So again, goes back to, you got to be a detective. You've got to figure it out. One other thing that I also do in addition to the pinwheel and the cotton swab is I have a little thing that is measured in millimeters. So I have from 1 millimeter all the way up to 15 millimeters. And I have the ability to poke a patient's finger. And if they can't sense that I'm poking them with something that has 2 pricks on it versus 1 prick, then that lets me know we have a sensory problem in that particular finger. And I could get a little bit more specific beyond the course of this, or beyond the scope of this course, but you can even go into sides of the fingers in order to figure out which particular longitudinal nerve is involved with that in that digit. So it gets very specific in order to try to figure out what is going on with this particular person. Why can they not feel all the way to the tips of their fingers? How much do they not feel? What nerve do we need to trace that back to? What can we look at to further prove that this is their problem? Now, some people will complain of pain in the wrist area that then sends painful sensations into the palm of the hand. For people who do that, we can then evaluate for carpal tunnel syndrome. Carpal tunnel syndrome is basically compression of that median nerve as it comes across what this is called the flexor retinaculum. So the flexor retinaculum is a little band of tissue that runs right here across your wrist. And if it is compressed right in the center, then that will lead to carpal tunnel syndrome, which can often happen if people sit at a desk and type all day. So their positioning of their hands, the poor ergonomics can sometimes cause that carpal tunnel syndrome, which will then affect their periphery. So I've had people who originally had carpal tunnel syndrome but didn't get it taken care of, And then whenever they don't get it taken care of, now they can't open jars anymore because that nerve flow is not going all the way to the tips of their fingers. They drop things. So weakness starts to set in. So very important to keep those nerves happy and healthy and well. Okay, so that was lots of detail for brachial plexus. As we move into the lumbar plexus, again, from T12 all the way down to L4. So you can see here, L4, then L5. So we're T12 to L4 for our lumbar plexus. Multiple different nerves. The main one that a lot of people talk about is the femoral nerve. So the femoral nerve will go on to innervate muscles in the quads, and then it will go on down to the medial surface of the leg and then down onto the foot. I think I have a picture of that. Let's look at this picture. Okay, so you can see nerves of both the lumbar plexus and the sacral plexus anteriorly on this view, posteriorly on this view. So whenever we are looking at that femoral nerve, you can see it right here, running down towards the quad area. Okay, that's the main one that people often talk about with that lumbar plexus. And again, sciatic nerve, the main one that people often talk about with the sacral plexus. If you look at, where's that picture? This one, pudendal nerve. So you can see here the sacral plexus is going to run from L4 to S4. The pudendal nerve, we can see right here, small little nerve. But the pudendal nerve is very important because whenever we're talking about pudendal, this is S2 through S4, muscles of the perineum, that means the outer portion of the external genitalia, skin of the external genitalia, the bulbospongiosus and the ischiocavernosus muscles. S2, 3, and 4 help you keep your pee and poop off the floor. If someone comes in, it sounds funny, but if someone comes in and they don't have the ability to control their bowels, they don't have the ability to contain their bladder, then we could have a serious issue, okay? So Cauda-Equina syndrome is what this will be called if they no longer have the ability to control bowels and bladder function. It is not a good thing, all right? So that would be the pudendal nerve, S2, 3, 4, helps you keep the pee and poo off of the floor. All right. Okay, sensory innervation of the foot as we move on down, so different nerves. Again, you can see here from the femoral or from the sacral plexus are going to go on, give us innervation to our foot. If you look, the tibial nerve, it's going to be on the plantar surface of the foot, but you do not have any tibial nerve innervation on the anterior surface of the foot. You have a little bit on the heel, okay? So there's divisions here, again, to check either pinwheel or Q-tip. Are you able to feel this? Do you understand the sensation right now? Obviously, they have their eyes closed, right? Do you understand that I'm poking you right now? Because I've had some people who are like, I'm waiting for you. I'm literally poking you right now. Do you not feel it? No, I don't feel anything. Okay. So that is definitely significant for we need to go back and look and see what is going on either within the peripheral nerve itself or go further up the spinal cord to evaluate for any nerve damage. So that's why we want to make sure that we understand where these different areas are where we can check to assess for proper nerve function. Now, as we've gone through all of that, okay, regardless of the plexus, regardless of where it's at from the cord, regardless as to the name of the nerve, regardless, whenever we're talking about reflexes, what we're talking about is rapid automatic responses to specific stimuli. When I said the example of Mr. CP not being able to feel the hot on his fingers, okay, That means that he also doesn't have the ability to be in the kitchen safely because he could touch something like a stove burner, which is hot, and burn himself. So we have these reflexes that will protect us and keep us safe so that we do not harm ourselves. But when that nerve is no longer functioning appropriately, then these reflexes start to diminish. Okay, so reflexes by definition are rapid automatic responses to specific stimuli. They are the basic building blocks of neural function, and a specific reflex will produce the same motor response each time. So we've got 5 components to the reflex arc, and this basically is going to be a recap, even though you think, well, we haven't learned this yet. You actually have, because I've walked through each of these processes with you, step by step in the teaching of all of this information. So whenever you're looking at this, it always has to start with some sort of stimulation, whether that is something that you touch that is hot, whether that is you walking outside and the temperature has dropped 30 degrees, whatever it is. We have receptors in our body that are going to pick up that sensory information. We have receptors in our skin that will tell us, is it cold? Was that hot? Does that burn? Does that hurt? Did you just pull my hair? Did something just land on my shoulder? You know, so all of this stuff that happens with the nervous system, all is going to start with the sensory sensation. The receptor has to pick up some sort of stimulation to let us know that something has changed. Now remember, the stimulation has to be strong enough to give us an action potential for the neuron to fire. Do you guys remember what the threshold was for the action potential? Negative 55, okay? So if it's strong enough to fire that action potential because we reached negative 55 millivolts, then we know that that sensory information is going to be carried through an afferent pathway in order for that information to then get to your brain or your spinal cord to say, what do we want to do with this? Okay, so that is step 2 that you guys have already learned, the sensory neuron, the afferent or afferent pathway that's ultimately going to carry the information from number 1 towards the central nervous system. Okay? Once we get in the central nervous system, then we can do the integration. And we can think, what does this mean? Well, what should I do? If it's a reflex, you're not going to have time to think. It's going to be an automatic response. Okay, if it's you touching a hot stove, there is no time for that to think. The information processing happens right in the spinal cord and it will come right back out. So that way you move your hand. Okay, so information processing in the central nervous system. Once we have that information processed, then we will send the information through a motor neuron in the efferent pathway that's going to carry instructions to what we call the effector. The effector is there to make an effect or to create a change. Okay, so in the hot stove example, the effector would be the skeletal muscles in your arms and hands that will immediately contract to draw your hand away from the heat source so that you don't just keep it there and burn the crap out of your fingers. So 5 components, make sure that you know those components. We always start with the sensation. Afferent information, that sensory information, is carried through which route to the spinal cord?
Dorsal.
Dorsal. Okay, that's why you got to know your anterior from your posterior on your spinal cord. Because step number 2 has to go through the dorsal route. The information we process, step number 4, has to go through the ventral route. So now that we've learned about spinal nerves and peripheral nerves, and now you know, okay, well, if I am feeling something let's get away from the hand burn example. Let's say if I'm feeling something crawling on the back of my right hand, kind of near my thumb and wrist area, if I feel something crawling there, that information is going to travel through the sensory pathway in the spinal nerve, ultimately get into the dorsal root, go through the spinal cord. We'll talk about this later, but it's going to ascend up to my brain. Once it gets into my brain, where does sensory information go once it gets to your brain? You guys are like, oh, this is too much. All sensory information except for smell goes here.
Parietal.
The thalamus. So the thalamus is going to then send that information to the primary somatosensory cortex, which is in, does anybody remember which lobe of the brain?
Somatic sensory.
Somatosensory cortex is where, in which lobe?
Parietal.
Parietal lobe. Okay, so parietal lobe will then tell you it's on your right hand near your thumb and your wrist. It's not on your left knee. It's not on your butt. Okay, it's on your right hand. Your parietal somatosensory cortex is going to tell you exactly where it's at. And then you can, with your eyes, look down and see, and if you want, you can flick it off. Okay, because that's the motor that's coming out. If you choose to do that and you flick it off, that's motor coming down, causing a change to an effector. Okay, there are different types of reflexes. The one that I just gave you is not necessarily a reflex, but that's how it's actually going to happen whenever you're looking at putting all of the information together that we've learned from the brain, through the spinal cord, through the plexuses. That's how all of it culminates together. Now, a reflex arc just leaves out the brain, because the reflex arc has to be fast enough for you to respond without you needing time to think about it. So whenever we do information processing in the central nervous system, then it's going to be in the spinal cord, through the dorsal root, out the spinal cord, through the ventral root, because it needs to be super fast. So whenever we're looking at those particular steps, again, this is me kind of like I just talked through all of this, but for those of you who need words, then there's your words. Whenever we look at all of this, you can see it in picture form here. Number 1, number 2, we've got our dorsal root, we've got our dorsal root ganglion, we've got the information processing in the spinal cord, and we've got information leaving through the ventral root, ultimately going to a muscle, which is our effector, in order to make a change. Okay? So in and out, and it's always in the same way, regardless of whether it's a reflex that doesn't need the brain or whether it does need the brain. It's always sensory in through the dorsal, motor out through the ventral. Sensory in through the dorsal, motor out through the ventral. It's always going to be the same. Okay? Yes, ma'am.
In that picture, it like is going just in one side. Is that just like if you have the stimulus on your left hand, would it go through the left side and then like vice versa?
Yes.
Okay.
That's correct. Okay? And there are different types of reflexes. So you can see here we have development, motor response, et cetera, et cetera. This video will basically walk you through. He's a great drawer. I don't think that I've used any of his videos in this semester yet, but this is one of my favorite guys on YouTube. And he does a wonderful job drawing through things and being very detailed and showing you how all of these things actually work. So instead of me going through and explaining all of these different types, these 4 types, I want you to watch this video so that way, A, you don't have to continue to listen to my voice. You can get a little bit of a different voice. But then B, that way you can actually see it in pictorial form as he talks about it. So he will walk through these innate reflexes. You can see that innate means genetically programmed or inborn. These are things that should naturally happen automatically in every single person. When a baby is born, if they're having a hard time with eating, then you can stroke their cheek and whenever you stroke their cheek, that's an innate reflex that makes them turn their head. And the reason for that is so that they will turn their head towards the breast, towards food. So that's an innate reflex that's inborn in all of us. Another innate one in babies is like whenever, if you've ever put your finger inside of their palm, and they will close their palm around your finger. I hate to be the bearer of bad news, but if you thought that was because the baby really liked you, not necessarily. It's because that's an innate reflex, okay? So there are innate reflexes that we're born with. There's acquired reflexes that we actually start to learn as we grow and develop. You had to acquire reflexes to learn how to ride a bike. You had to acquire reflexes to learn how to avoid bad drivers on the highway and not get in accidents because somebody else did something that made no sense at all whatsoever. So those are developmental reflexes. They can be innate or acquired. We have motor responses, somatic reflexes. Remember, somatic means skeletal muscle. Visceral reflexes, meaning organs. And then we have different complexities. So a monosynaptic reflex would be like the burn reflex that I just talked to you guys about, where we just have a single synapse, and polysynaptic means that we have more than one. Okay, so he'll walk through all of that with you guys. You'll be able to see him draw those different reflexes and then explain them. I think he does a really good job of that. So do take a look at that video so that way you can see those drawn out as he discusses the different types of the reflexes.